Hi, everybody. Welcome to our session on operationalizing the direct contracting model. I'm Mara McDermott with McDermott+Consulting, based in Washington, D.C., and have the great pleasure of moderating this session today. I'm going to let each of our panelists briefly introduce themselves, talk about their role in the direct contracting model, and give a little bit of background on their organization. So I'll just work my way around my Zoom screen. So Eric Becker, if you don't mind kicking us off, I'll let you go first.
Sure thing. Thanks, Mara. Appreciate it. And really excited to be here today. My name is Eric Becker. I'm the Vice President of Direct Contracting and Medicare Innovation Model Strategies with Agilon Health. For those of you not familiar with Agilon Health, we're a value-based care company, traditionally focusing on partnerships in the Medicare Advantage space, but obviously we've also moved into direct contracting and the Medicare fee-for-service space. I've been in this role for about a year and a half, focusing almost exclusively on direct contracting and Medicare innovation models. But prior to that, I worked on physician engagement strategies here at Agilon and with Providence Health and Services in Southern California. So in the role, I lead operations across all of our DCEs. We have 5 DCEs that are currently live across 7 physician practice partners in 7 geographies. We have alignment in those models of roughly 50,000 beneficiaries. And all of our DCEs are standard DCEs. We're taking global risk for all of them. And we're taking primary care capitation for all of them. We'll get into what that means in a second. So again, really excited to be here. And Mara, I'll hand it back over to you.
Great. Thanks so much. Eric Cragun, you want to go next?
Yeah, again, like Eric Becker said, really excited to be here today. Thanks for the opportunity. My name is Eric Cragun. I'm the Executive Director for Government Programs at Castell. Castell is Intermountain Healthcare's population health subsidiary. You're probably familiar with Intermountain Healthcare. We're based in Utah with 23 hospitals in Utah, plus operations now in both Idaho and Nevada. We've been participating in the Medicare Shared Savings Program since 2018 and in other local ACOs in both Idaho and Nevada. In 2021 here, we moved our Nevada providers into the global track of direct contracting. Got about 7,000 lives right now in Nevada. And then for 2022, we're hoping to move our Utah and our Idaho providers into the direct contracting model as well. And again, same thing in Utah and Idaho. We anticipate being in the global risk track and taking primary care capitation, and look forward to chatting about all that.
Great. Thank you. And last but not least, Kim Kauffman.
Hey, Mara. It's great to be here. Nice to spend time with Eric. And Eric, I feel like I'm running with the big dogs now. So I'm the Chief Value-Based Care Officer for Max Healthcare and Best Value Healthcare based in Tampa and Southwest Florida. We're a primary care group focused on geriatric medicine, rock stars in the Medicare Advantage, capitation, global risk arena. We actually have 2 DCEs. We have one, the Max Healthcare DCE, that is a standard global PCC, like everybody else on the call. But that organization and those primary care physicians have been in the ACO game since 2014 and just have been kind of doing this nice projection along the risk track. Our other DCE is a new entrant professional, again, PCC, and we have about 7,000 lives in that model and 3,000 in the new entrant and 7,000 in the standard model. So excited to be here and learn from my peers.
Kim, just real quick, I'm going to pick on you for those who are not immersed in direct contracting lingo. Give us the 101 on new entrant versus standard.
Sure. So the new entrant is the model. CMMI wanted more groups to come into this space to manage the patients with traditional Medicare. And so they gave this opportunity for people who don't have experience, don't have background in it. Maximum size is that you would have had about 3,000 alignable patients back in the benchmark base years. And growth is meant to be somewhat controlled and contained for the first 3+ years of the program. The benchmark is also a bit different, again, because it's meant to be for providers who've not historically taken care of traditional Medicare patients. So it's a different benchmark than the standard model benchmark.
Thank you for indulging me on that one. So I want to talk a little bit about the model itself and what's going on the ground. So here in Washington, D.C., there's been a ton of interest in this model. Unlike anything I've seen as a student of value-based care for a lot of years, certainly a lot more enthusiasm than MSSP or Nextgen or Pioneer before it. Lots of new entrants, as Kim mentioned, and new types of players. And I would say just general high level of enthusiasm for the model and around the model and critiques as well, which we'll maybe get into a little bit. But I'm curious what is out there in what I lovingly refer to as the real world. What is the level of enthusiasm and interest among physicians? And Eric Becker, I'm going to throw that to you first.
Yeah, thanks, Mara. So I think similar to what you're seeing, what you're hearing, Mara, we are seeing a lot of interest. We're seeing a lot of enthusiasm, a lot of engagement, a lot of questions, particularly in the last couple of weeks, because this has been the deadline when groups need to make decisions about whether they're joining the model and who they're joining the model with. So a lot of groups, and potentially less traditional and smaller groups, reaching out asking about it. I think part of that is just the general buzz that you spoke about. There are a lot of new entrants that are creating a lot of energy behind this, and so we have a lot of groups asking us questions about direct contracting. What is it? Should we join? How do we join? So a lot of interest and enthusiasm. In terms of our groups, we are again a little bit different because our traditional focus has been with Medicare Advantage. We came into the model with existing partners, and we had already had an existing and established Medicare Advantage line of business with the partners that we are currently in direct contracting with. And they came to us initially asking us about this model at this point, almost 2 years ago. They were interested in a way to move all of their patients, all of their Medicare beneficiaries onto a single platform, aligning all of them around value-based care. They had heard about this new model, and so they really encouraged us and worked closely with us to apply for direct contracting. So that's our background, and I'd say 4 months into performance year one, and I'm curious what the others are hearing as well. And we continue to hear enthusiasm from our groups that are participating. They're particularly happy and pleased with the simplicity of the model in terms of how it's experienced by physicians. So we have simplified quality measures, less reporting. If they're coming from MSSP or they're coming from a CPC plus model, there's a lot less burden on the practice now. Obviously, a lot that agilon is doing to administer the model, but it's less for them, and it allows them to focus on the things that they need to focus on and take good care of patients and to perform well in a value-based care environment. So that's what we're seeing so far.
Yeah, I know that alignment across payers has been huge, and something that I think we continue to hear providers pressing for. I'm curious, one factor you didn't mention, but I wonder if it's playing a role is COVID. I think one thing that we heard early in the pandemic was sort of this cohort of providers, not everybody, certainly much more interested in value-based care because that real vulnerability of fee-for-service had been exposed during the pandemic. And anybody can feel free to jump in on this. That doesn't have to be Eric Becker, but I'm wondering if that's another factor that you all are picking up out there as you talk to primary care providers in particular.
I can jump in here. I would echo the same thing. I think that providers who are used to managing under capitated arrangement and if you're in Medicare Advantage, this is such a complementary with an E, such a complementary strategy, because there will always be patients who will not sign up for Medicare Advantage for a number of reasons. They have employer-sponsored secondary insurance, or maybe they got burned by managed utilization back in the 90s, right? The first time we did this and we didn't do it well. So I think that it's a really complementary strategy. And also providers who were really beholden on fee-for-service. COVID was definitely a lean year. So if they were comfortable with capitation for them, this is just a natural extension. Also, the MA-like levers that are available in this model, the ability to contract out for your own virtual narrow network. Of course, we still have to honor beneficiary choice, but those kinds of MA-like levers, again, made it kind of just a natural extension of managing these traditional Medicare patients the same way we have Medicare Advantage patients. So a lot of enthusiasm among the providers. And to echo Eric's statement, it is significantly easier from the provider perspective.
I'd offer just one other thought there. So we work with maybe a slightly different group of providers, many of whom have yet to take on capitation. We have the employed Intermountain medical group, and they have more experience with risk-based models, but we also have a lot of affiliates of the Intermountain healthcare system who are still in the fee-for-service business. And I think we still yet haven't seen as much interest from those groups in joining direct contracting. I think capitation is still a big leap for, or it feels like a big leap, even despite what happened last spring with the pandemic and the kind of dramatic decrease in volumes for a couple months there, and the drop in revenue. I think there's still a lot of hesitancy, a lot of caution for some fee-for-service groups, folks who haven't had experience there, to make the leap to capitation.
Thanks. So we're going to dive a little bit deeper into some of the operational challenges, but with direct contracting or operational issues. But one of the things I wanted to kind of just set the stage with is really how different is it to operationalize this model as compared to predecessor models. And so I think one of the things that has garnered so much attention is that there's a sense out there that this model is something way different, much closer to MA, nothing like Nextgen, nothing like MSSP. And I'm curious if that's true from an operational perspective. So Eric, Cragun, maybe I'll stick with you for a second to talk about any sort of key differences that you're seeing, or what's happening on the ground in terms of those operational issues.
Yeah, and we can go into some depth on these if we want to, but I'll hit on just a few at a high level for a second. And for context, we've been in a Medicare shared savings program model, and I think one of the biggest differences moving from MSSP to direct contracting is that we go from participating at the TIN level to participating at the TIN NPI combo level, right? And so we went through this exercise across the course of the summer here to think through which of our providers made most sense to include in this model. What are the trade-offs between including some of our specialists, some of our providers who practice in urgent care settings in the model, right? There's a whole lot of opportunity to think about how we're participating. And then there's a lot of work too to make sure that the rosters are right, that the information's all right in the direct contracting online portal. And that's something that with MSSP, just a much simpler experience, solely because we just had to load a TIN in, and then the rest of it all happened on the back end. So there's that piece. I think attribution is different in this model, and I think lower than we had anticipated. And it has sounded like that's not an uncommon experience around the industry. And we're still trying to determine if that's good or bad, but lower than we expected. And a couple other things, and then I'll pass it along here, but the rate book approach is different. That's something that we're still adjusting to. The data has been a little more difficult to adjust to. It's not quite the same as MSSP. And then I think, Eric referred to this earlier, but with less quality reporting, and in fact, in the first year with only claims-based measures, the operations, at least around quality reporting, are much more simple. I mean, it's basically submit your claims to CMS and they'll take care of the quality reporting for you the first year at least.
Definitely. I'll jump in because I was responsible for an MSSP ACO back in summer of 2012. And I will say that while CMMI has had some hiccups since April, still much smoother going than when MSSP first started and they were redacting data and we were, having to test that we were destroying, dirty, we called it the dirty data. And then I also have accountability for Nextgen ACO. And to me, the DCE is not very different than the Nextgen. I mean, in Nextgen, you had some benefit enhancements, you had some APO or preferred provider contracting opportunities. It was at the NPI level. So to me, this is not that different. The quality measure is much more simplified. I'm a little nervous about the continuous improvement and the SEP. What is it? Sustained exceptional performance. What's the criteria? What are our thresholds? I feel like I'm flying a little bit blind, but Eric, as you said, it is pay for reporting basically, and there is no reporting in the first year. So I can't complain too much, but that's probably the biggest delta is the quality reporting piece.
Yeah, we also observed a lot of similarities with Nextgen, and I think we've heard that some maybe more challenging financial model, but lots of similarities in terms of operations with Nextgen.
Yeah, and I think it's worth just calling out. Kim mentioned that it's been a relatively smooth rollout for a new model. I know there've been some bumps along the way, a change in administration, a couple other things, but I think this is a really great CMMI team to work with right now. They're very engaged. We've had lots of continuous calls with them to address some of the issues that have popped up. And again, there have been bumps, but it seems like, for at least for us working with the team, it's been a really good rollout.
Yeah, and I think the issues, Eric, that you spoke about earlier, related to provider rosters and getting all of those things kind of set up. And again, we're all going through this right now, so this is what everyone's been focused on for the last 2 weeks to a month. That's very real. I mean, compared to MS, we worked with one of our partners on MSSP before we started direct contracting, and that was a much simpler approach. This takes some time. So groups that are moving into direct contracting will want to devote plenty of time and really resources within the organization to making sure you have a process for dealing with rosters, for updating them throughout the year, and certainly for the big submission in September, because it is a big deal and there's a lot of complexity there.
We won't speak ill of 4I. Let's just move on.
Yeah, we're recording this 3 days before the final deadline to have all this in 4I. So behind the scenes, we've all got frazzled teams that are trying to get the final details right. But it's it's been good experience working with the CMMI team, and they've been accommodating where they've needed to be. And it's, we'll get there for 2022, I think.
Yeah, I completely agree with that. There have been little things that have popped up, but even today there was something that popped up, and they were working on it with their software team right on the spot. And so as issues come up, they're being very responsive. Little things, but again, that's why it's great. It's important to take all the time that you can and to leave yourself plenty of time, because there are always unexpected things that happen at the end. And if you're scrambling that last day, you won't have time to fix them. Luckily, the team has been really responsive, and I think we're going to be in good shape by the end of the week.
Yeah, and I think it's fortunate that this team in particular has so much experience with Nextgen and some of these issues, although new in some ways, that familiarity and kind of baseline. Speaking of that, I want to talk about one of the features, I would say more, maybe not new to direct contracting, but more widespread in direct contracting than in Nextgen, which is claims reduction and the ability, I think, really for the first time in a very widespread way to get more physicians off of the fee-for-service chassis, which is an exciting element of being in a CMMI model, but brings along some, I think, challenges and opportunities. So, Eric Becker, I'll throw to you first to talk a little bit about what you're seeing from an operational perspective in terms of implementing that claims reduction.
Yeah, thanks, Mara. So we did not implement the claims reduction in 2021. We did partially with a handful of preferred providers. So we entered into a preferred provider. We created a preferred provider network, and the model gives you flexibility to enter into fee reduction agreements with preferred providers, and then it makes that mandatory for participant providers starting in 2022. So we do have some fee reduction agreements in place with our preferred providers. We've been working through that this year. Next year, it's going to happen on a much bigger scale with our participant providers. We've been similar to what was mentioned before. There are various levels of comfort with taking a mandatory fee reduction from CMS and then converting it into some sort of downstream arrangement with the DCE. We have groups that are signing up for full fee reductions. We have other groups that are starting off at the minimum, which is 5%, and then we have some that are somewhere in the middle at 50% or 25%. So we're really running the gamut in terms of the fee reduction that practices are going to be taking. We're going to be replacing that fee reduction with a per beneficiary per month prepayment. So there'll be a prepaid arrangement with the practices. We will not be trying to pay claims. That's not something that we wanted to sign up for. But we know that some DCEs are going to be replacing the fee reduction with claims payment. So we're replacing it with a prepayment. It's not really a capitated payment. It is more so a prepayment. And I do think, to your point earlier, Mara, the experience with COVID last year, I think, made that a much easier conversation. There was a lot more receptiveness to the idea of steady cash flow throughout the year because of the reduction that was seen in 2020, and the place that put a lot of practices in. They were in dire straits for several months, and so the conversion to this type of model was of great interest.
Kim, anything you want to add on that piece?
Sure. We ripped the Band-Aid off with our participant providers. So our participant providers are all primary care docs, and we had all of those contracts in place before CMMI came back and said you could kind of wade into the capitation pool. So we just went with 100% fee reduction, and all of our primary care providers are capitated. So that's been in place for a while. Has been well received. And the enhanced portion of that primary care cap, we're seeing it being used as CMMI intended it. We've got affiliate providers who are investing in a bit of infrastructure and some care management, care coordination, social workers, those kinds of resources to better manage those patients. So that's good to see. For 2022, we're really focused on the post-acute piece. And though I know this airs in a couple of days, but our deadline is it still close of business the 16th, right? I think, or the 16th to have all our agreements in place. So we're down to the wire. And when we finish talking today, I'm going to be back on the phone lines finishing up those fee reduction agreements. And so it's a nice lever. It's always good to try to have utilization be appropriate. And I think now we have an opportunity to partner up with some post-acute providers who are willing to put a little bit of their earnings at risk on the promise of delivering better outcomes for our patients. So I'm looking forward to 2022 and what we're going to do for the post-acute.
Yeah. I was going to say, I'm sure your teams are thrilled that I have you on here to talk about how smooth operationalizing it is going. They're in the back. I envision them all like frantically typing out emails to you.
Yeah.
Well, that's all really interesting. And I know we're going to be very interested to see how that plays out, both in the 21 results, but also in 22, as we see some broader experimentation with those claims reductions. One of the other big features or things I think has gotten a ton of attention, but isn't all that new to the ACO space, is voluntary alignment. So this idea that the beneficiary can elect your DCE. Eric, Cragun, I'll go to you first. And I wonder if you all have had experience with this, both in direct contracting, but also outside of direct contracting, whether it's something you all have tried.
Yeah,
and if not, why not?
It's a good question. We looked at this a little bit in MSSP, and as we send out the required notification letters for MSSP, we're not even asking people to sign up for anything. We're just telling them that they're attributed to us as an ACO, and the confusion that kind of emanates from those letters has been significant enough that we haven't really pursued anything with voluntary alignment in MSSP. And so far we're taking kind of a cautious few steps towards that in indirect. I think our focus early on here is we've got enough members attributed to us in direct contracting that we don't need the voluntary alignment to stay in the program. And so initially here we're really focused on improving the way that we manage care for those patients who are already attributed to us. And then we're kind of laying the groundwork for starting to do some of the voluntary alignment. Interested to see if the flexibilities in this model do resonate better than what we've seen in MSSP with patients. But I think we're early in this still and don't have much specific to report there yet.
Eric, Becker, anything you want to add on voluntary alignment?
Yeah. So we did not come from a model where we were doing a lot of voluntary alignment in the fee-for-service space, but we are doing a significant amount of voluntary alignment now. It's taken us a little while to get to this point to kind of ramp up. There is a process that's in place similar to other models where the team has to approve your voluntary alignment marketing plan. That took a little bit of time, but we have our plans approved. We've learned from what worked in the past, and that's become a much smoother process. We've taken a few different approaches to voluntary alignment. So we have a robust process in the offices. So our offices are slowly rolling out voluntary alignment to beneficiaries. We've also sent mailers out. Mailers are kind of mixed in terms of how successful those are. And we've also, for one of our DCEs, started in an electronic process as well, doing voluntary alignment through electronic signature, through e-signature, and via email. So there is more flexibility in this model in terms of what they're allowing for voluntary alignment outreach. And electronic, I think, is new. I don't think they've allowed that in the past. And now they are allowing e-signature, which for some seniors is a really preferable approach. So I will say that the team has been pretty flexible here. We think that there's some opportunity, and we're not we're really focused at this point in the early stages on retaining beneficiaries. So we're focused primarily on beneficiaries who see a provider who's retiring, because otherwise you'll lose that alignment heading into the next year in the model. Patients who maybe haven't been coming in as often and we're worried about them falling off of attribution. And then also beneficiaries who come in frequently, but for some reason have fallen off alignment. We're trying to make sure that when there's the opportunity, that we get them to focus on the voluntary alignment form as well. And we've had really good reception of this process in the office. Again, the mailer is a little bit more difficult, less reception via mail.
I think we've had great success in our offices with patients who are already claims-based aligned. They're happy to fill out the form, and I kind of belt and suspenders. So okay, we'll take your form and we'll submit it through the process. But if we've got 10,000 or so attributed patients, we just went through our first submission process here, middle of last month, I think, because Eric, like you were saying, it took us a little bit to get our plan submitted and get it sorted out. But for about 2,400 patients who are not already attributed to us. So we'll see how many of those, make it through eligibility and wind up being added to our October 1st roster. So we're excited. We are picking up speed. I think the teams are just getting more and more adept at doing that. And frankly, we've gotten better at using our EMR to pre-populate those forms. So when the patient presents, it's easy. On also making it part of the virtual rooming process. Again, here in Southwest Florida, hospitals are full again with COVID. And so we've switched back to a bit more virtual. So needed a virtual rooming process that included a voluntary alignment option. So there's a learning curve on it. I do think it would be interesting, Mara, to watch that. I'm sure that somebody out there is going to start playing benchmark bingo, with the way that voluntarily aligns patients who cannot be claims-based aligned, right? How they impact a DCE's benchmark. Somebody's going to run amok on that one. We'll have to see how that turns out.
Yeah, I have a feeling we're going to learn a lot of lessons out of this model from various opportunities to learn some lessons about delivery system reform, including that one. And Eric Reagan, just to come back to something, I feel like we've been talking about this challenge with the beneficiary mailers since 2012, since Pioneer. And so it feels like maybe there's a work group opportunity there or something. So there's something to be done there.
Yeah, I think one of the great promises in direct contracting is figuring out a better way to engage traditional Medicare beneficiaries. I think MA plans have had years to figure out how to do that. And I think in traditional Medicare, there's still a gap there. I think about my own grandparents and kind of the way they understand how the healthcare system works and ACOs and insurance and all those pieces. And there's some real running room to innovate. And I think direct contracting is a really good forum for that.
So we've covered a lot of challenges. I'm going to ask you all we're going to go around. I'm going to ask you to weigh in. If you were going to give one recommendation to CMS with regard to operationalizing this model, what would that be? Recognizing they've been a great partner and we'll probably listen to this and fix it for you. So we'll start with you, Kim.
Well, there's the upstream participation agreement is a mere 290 pages of really dense reading, right? And I literally just had to send it out to every provider, right? And the 10 executives for every provider. But I think, and so I always kind of snicker during any call office hours where they say, well, it's in the PAR agreement. Well, it's 290 pages. So if there's, maybe a Cliff Notes version of that, or maybe they could, give us a couple of CEUs and school us on it, because it is the primary source document there, and it is difficult reading, and not everybody has fabulous legal resources like Mara's team available to interpret that. But that, I think that it feels like in some ways they have some opportunities to simplify the participation agreement and some of those requirements. Just I would start with that because that's so essential and it's the primary source.
I like it. Feels doable as well. Eric Cragun, you want to go next?
Yeah, the one piece that we've run into just a little bit are issues with the data. So we've been in MSSP. The CCLF file format is still kind of the core file format in direct contracting. And so Fortunately, we haven't had to adapt much there, but the eligibility files, I think we have run into a few issues there. And then the claims reduction files, the files that we get back from CMS that help us understand which claims were reduced and what those amounts were. It's been just a little tricky to work with those. I know we've had some good dialogue with CMMI. I think they're working on trying to continue to improve the data that we receive, but that's one that it's so core to being able to function well in this program to get that data right. So we're eager to see it continue to improve.
Thank you. And Eric Becker.
Yeah, thanks, Mara. I think for us, the key recommendations would be around visibility throughout the performance here. This was alluded to throughout the conversation today, but there are a number of different areas within the model where the actual number that will be used won't be clear really until final reconciliation. Those are things like the coding intensity factor, which we didn't really talk about, but will have an impact on risk adjustment performance. The retrospective trend adjustment, if that exists, and especially given COVID and changes in utilization, it seems like that could be different than what we've experienced in the past. And then I think, as was alluded to earlier, in terms of quality performance, very difficult to calculate the quality measures on our own. So far, we haven't received any data related to quality and the cut points, what the actual benchmarks that will be evaluated against. Those, at least for now, won't be revealed until reconciliation. These are really important things. These could swing your performance pretty wildly, and we need line of sight to them well in advance of reconciliation. At reconciliation, obviously, there isn't a lot we can do about those items. So that, I think, visibility would be the key thing. As much visibility as possible, as early as possible.
Yeah, it's really been a learning curve, I think, with CMS as we move off of fee-for-service and into these more prepaid models, getting to the same level of transparency and predictability as Medicare Advantage plans have, right? So like really committing to that in advance and providing all the details the provider needs to be successful. On that happy note, we're going to have to leave it there, unfortunately. I feel like we could talk about this for many more hours, but want to thank the panelists for joining today. You can connect with all of us through LinkedIn and ask any additional questions, and we appreciate your time and look forward to seeing you at future conferences, hopefully in person.